first thing we're going to cover is just the normal anatomy of the waveforms. So on the board up here we have your typical waveform layout. You have your pressure waveform up top, your flow in the middle, and then your volume at the bottom. So we'll start with pressure since it's at the top. And how this is supposed to look is as we go into inspiration, you're going to be riding your PEEP, and then the breath initiates, and we're going to go straight up until we hit our peak pressure that we want. And then we should ride that line once we hit there. It's holding that pressure, so throughout the inspiratory phase. After the inspiratory phase, we should drop back down to our PEEP, where then we will ride out on the PEEP until the next breath is started. So it's going to go up, and then it's going to flat top over, and then go back down. With your flow waveform, at the start of the inspiration, we're going to go straight up again. We're going to hit our peak inspiratory flow here. And once we hit our peak inspiratory flow, then we are going to have a smooth deceleration back towards zero flow. And that deceleration is showing us a deceleration of the amount of flow moving in the lung is decreasing over the inspiratory phase until we get down to zero flow. So this baseline right here. And what is zero flow? Zero flow is when there's no longer any movement inside of the lung. So if you were to take a deep breath, when you get to the biggest breath that you can take, that would be you coming down to hit zero flow on your inspiration. And then when you exhale out, we go down here to our peak expiratory flow, and we're exhaling, exhaling, exhaling. The amount we're exhaling is going to be less and less and less the longer that we exhale, until we get to back to zero flow, to where we can't exhale anymore. The volume waveform at the bottom, so you're going to start here during inspiration, you're going to deliver your inspiratory volume. So this first part going up is like your inspiratory volume, and then your second part coming down is the expiratory volume, returning back to the vent. When we set an inspiratory cycle off or end inspiration, we are talking about the spontaneous breaths that the patient may have, so your pressure support breaths. And what the inspiratory cycle off is at what percentage of our peak inspiratory flow are we going to cycle the breath into exhalation? So how we're helping control how long the inspiratory phase is for your spontaneous breathing patients and your spontaneous breaths. So when you're setting this, on this first one we have here, your inspiration starts, we go up to your peak inspiration. So if we look at this like this is 0 and this is 100% of that peak inspiratory flow. As we decelerate, when the amount of flow movement in the lungs gets to a certain percentage compared to that peak, we're going to go into exhalation. So for here, if you were to drag this over, that would be like 10%. So this would be like if we had it set at 10%. On this one, if we were to draw this over, this looks more like it's set at about 30%. And with your inspiratory cycle off, the higher the number, the shorter the inspiratory phase is, and vice versa. We can use waveforms to determine a few different things going on when we start a patient on mechanical ventilation. We can look and see if our settings are appropriate. We can look and troubleshoot some things going on with the patient. So that's what we're going to talk about now. And the first thing that we're going to go over is what does it look like if you set your rise time or your flow rate too fast. And so if we look on the board, these are what you're normally supposed to look like. If our rise time is set too fast, we're pushing in flow at too fast of a rate, our flow rate is too high. You're going to see it on two spots. You're going to see it on the flow waveform, which is here, and you're going to see it on the pressure waveform, which is here. What it's going to look like is instead of it going straight up and flat top and then back down on your pressure waveform, it's going to go up and overshoot your pressure because your flow rate is too fast, and then it'll come back down, and then it kind of regulates itself out, and then it'll drop back down. I call this, looks like a Batman ear to me. On your flow waveform, instead of going up straight and having a smooth deceleration down, we inspire and we overshoot this pressure. Then the flow rate that we're pushing in has to drop so that we come back down to this pressure. So instead of having a smooth deceleration, you're going to see it drop out kind of fast. And then as it resettles, you'll see it get more into a decelerating flow like that. If your rise time is set too slow, you're also going to see it on the flow waveform and potentially the pressure waveform. So in your flow waveform, instead of again seeing it going straight up and then decelerating down, because it's too slow, the flow rate isn't fast enough, we're not going to move straight up. You're going to move at a more slanted direction before coming over this way. And on your pressure waveform, you can see it kind of the same thing, where instead of coming straight up, it'll lean a little bit this way before it hits its pressure and holds. I remember this by thinking of it as almost like a shark fin. Next, we're going to go over what it looks like if your eye time for mandatory breaths is set too short. And where you're going to see that at is on your flow waveform. And as this inspiration starts, again, we go straight up. And then when we hit our peak inspiratory flow, the amount of movement inside our lungs is going to slow and slow and slow at a decelerating pace as we're heading towards zero flow. But if our eye time is set too short, we won't reach zero flow before we go into exhalation. So because we're controlling the eye time with mandatory breaths, we control how long that inspiratory phase is. And in this case, it's literally meaning that there's not enough time for us to reach zero flow. So our eye time is technically too short. For troubleshooting that, there's really a couple things you need to look at. It's not as simple as just going, oh, we're going to stretch the eye time out. The first thing you're going to do when you see this is you want to look at what is your I to E ratio. For instance, the respiratory rate was set at 20. We would take that, do 60 divided by 20, which would give us a total cycle time of 3. So every 3 seconds we would have a breath. Now let's say that our eye time was set at 0.5. So if our eye time is 0.5 and our total cycle time is 3, then that means our expiratory time is 2.5. And if we were to ratio this out, this 0.5 will go into 2.5 5 times, so we have a 1:5 ratio in this scenario. If that's the case, then you have room to stretch out your eye time, so you could do that. But let's say, for instance, our eye time was set at 1 second. Then that means our expiratory time is going to be 2 seconds, and we are at a 1:2 ratio. Well, if we're already at a 1:2 ratio, we might not want to stretch out the eye time anymore to give us more time to reach zero flow. And if we were at a 1:1 ratio, we definitely wouldn't, because we don't want to go into inverse ratios. So, what does that tell me? If we're not able to reach zero flow and we're at the 1:1, 1:2 ratio, what that gives me an indication of is that our patient's lungs are compliant, because they're letting me know that they're still trying to move when the inspiratory phase is going on. So before you see this and go make changes to your eye time to try to get the patient to reach zero flow, double check your I to E ratio. Make sure you're not too close to a 1:1 or 1:2 ratio, and that your patient isn't just really compliant. For mandatory breaths, if we set an eye time that is too long, you're going to notice that on the flow waveform as well. And what that'll look like is when we go into inhalation, we go straight up, we hit our peak inspiratory flow, and we decelerate down and hit zero flow. But we don't go straight into exhalation. Instead, we sit here at zero flow and then later on go into exhalation over here. So this little part right here, imagine yourself taking a breath, breathing in, breathing in, breathing in, breathing in. You get to where you can't take a breath anymore. And now we're just doing a breath hold. So this riding of zero flow right here during the inspiratory phase is a breath hold. So in this case, we're going to most likely want to decrease our eye time so that it looks more like this one, where we hit zero flow and go into exhalation. Because even though a breath hold every now and then may be a good recruitment maneuver, it's not something you're typically going to want every single breath that the patient has in their mandatory mode. If you can't get it to go away, you can talk to the doctor, let them know what's going on, and see what they want to do. Now we're going to go over what it looks like if your patient has a leak, and where you'll see that is on the volume waveform. So again, if we go over this, you have your inspiratory volume, which being delivered to the patient on this side, basically the first half of this. And leaks are going to occur on that inspiratory phase of the breath. As we're pushing in flow, flow is leaking out somewhere. And so the visual representation of having a leak is that the exhaled tidal volume coming back to the patient is going to be less than what was pushed to the patient. So when we push in our inspiratory volume, as we're coming back, it won't reach its baseline. The bigger the leak, the sooner it will drop straight down. So this picture has a bigger leak than this picture. If you were to look at it like this middle line, where it meets at that middle line, this would be 70% leak. This would be like a 35% leak, just kind of visually looking at it. The sooner it drops, the bigger the leak. Now let's look how trapping or auto peak is represented on the waveforms. And this is going to be on your flow waveform. So we're going to go into our inspiratory phase. We're going to decelerate smoothly to 0 flow, and then we'll go into our exhalation phase, hit our peak expiration there. And then we're going to start exhaling, 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 exhaling. Well, if the next breath starts right here, then it would go like this. And then it would go into your next breath and stuff. When we're not reaching 0 flow on this expiratory side, that means we're trapping some of this breath in here. We're not able to get out all the flow during the exhalation phase. And so the visual representation of that is here. The further away this is from this 0 flow line, the more you're going to be trapping. If you have secretions, or let's say you have a bunch of water in your tubing, you're going to be able to see that on the waveforms as well. It's primarily going to be on the flow waveform, but you can sometimes see a little bit on the pressure waveform as well. And it's going to be on this expiratory side of your flow waveform. When the patient's exhaling through, it's going to look like some squiggles coming up like that. And you can sometimes see that here as well. If you have a patient that has an obstruction, we're going to see it mainly on pressure waveform. Most of the time you see this, it's going to be with non-invasive patients who have full face mask. And generally they are just in a bad position, and that's causing them to obstruct. And so you would just have to go reposition them. And instead of it going straight up and making a smooth plateau over and then coming back, it's going to go up and then kind of look like this. And then I've even seen it look like that, where they're separated out a little bit. For me, I call this the McDonald's sign, or bunny ears. If you see that, again, most of the time it's going to be on non-invasive, so go reposition your patient and see if you can make it go away. Next, we're going to talk about what it looks like if your inspiratory phase is too long. So earlier in this video, we've talked about inspiratory cycle off for your spontaneous breaths. We've talked about some eye time things for your mandatory breaths. We've even talked about if your eye time is set too long, what it looks like on your flow waveform, where it hits here, rides 0 flow, and then goes back up and has this breath hold. But there's something else that can tell us if it's affecting your patient, and that's what we're going to talk about here. So whether it be your eye time is set too long like that, or if your inspiratory cycle off or your end inspiration percentage is set too low, then our inspiratory phase is too long, and it's long enough to where our patient is starting to breathe back against the vent. And when they breathe back against the vent, anything that they add to the circuit is just added on to the pressure that's in the circuit already. So on your pressure waveform, what you're going to see is that once we start inspiration and hit our plateau right here, we hit our peak pressure, and it kind of flattens out, and we start to go in through our inspiratory phase. Once it hits the point where it's too long for them and they start to breathe back against it, you're going to see a buildup of pressure on this right side that kind of looks like that. So when you see that buildup of pressure, that's letting you know they're starting to breathe back against the ventilator. They're adding excess pressure to the circuit because of that. And so what you'll have to do is go figure out on what breath is it happening. Is it happening on my mandatory breaths and our eye time is set too long? In which case you would see something like this. Is it happening on a spontaneous breath where we're just going way down here and we have this set at like 1%? If that's the case, what you're going to do is go up on your percentage, because if I put it to 25%, let's say, then I would cut it off like right here, and we would cut this much of the breath off time-wise. And so then that would put them in their inspiratory phase on their spontaneous breaths for less time, and they would get more back to looking like this. Now we're going to talk about how you can look at the flow waveform on a patient and trend how their flow waveform looks to see if their compliance is changing at all. So if this was a patient that was on the same exact settings for all three of these waveform shots, let's say, and this was the first one, and this was the second one, and this was the third one, right? So you have your inspiration, expiration for 1 hour, and then another hour you have another inspiration, expiration, and then some other hour you have this. You can look at these waveforms like this as long as all the settings are the same, and you could trend how they're doing. And so how you can look at it is the sooner that they reach zero flow at these same eye times, the less compliant they are. So in these scenarios, this lung right here, this shot right here where you go up, down, and we have this inspiratory hold because we reach zero flow so quick, this would be your least compliant state of that lung. And then here, this is how we want it to actually look, where we hit zero flow and go straight into exhalation. So if we go from here to here, from this shot to this shot, our compliance has actually gotten better. And same thing here. If we get to the point where now we're not even able to reach zero flow in that time frame because we're still trying to inflate, that means we're more compliant. So 1 is the least compliant, 3 is your most compliant in this state. And so if you had a kid that was here, and then you go in and do a vent check and nothing has changed setting-wise, and they look like this, they're worse. If they look like this, their compliance is actually a little bit better. And if their compliance is better and you look like this, then you go back to, okay, what's our eye to E ratio? Can we stretch out our eye time? We need to talk to the doctor. What do we need to do? Do we need to make some changes?